major factors, right, that determine oxygen delivery. Oxygen must be in the blood, then I must create enough pressure, right, to get it to the tissue, get blood flowing to the tissue. In what form does oxygen exist in the blood? In what forms does oxygen exist in the blood? Oxygen exists in bound form, right, and free form. So oxygen will exist in bound form in the blood and the free form, right, which is like the dissolved oxygen or the gaseous state. Which protein does oxygen bind to in the blood? What protein does oxygen bind to in the blood? Anyone? What protein does oxygen bind to in the blood? What is the carrier of oxygen in the blood? Hemoglobin, right? Hemoglobin, right? So hemoglobin carries oxygen in the blood in the bound state. Oxygen is bound to hemoglobin. So how much oxygen I have in the bound form depends on what? How much hemoglobin a patient has in their blood. Hemoglobin level as well as hemoglobin saturation, right? So the bound form of oxygen, which is bound to hemoglobin, depends on the hemoglobin concentration or levels and hemoglobin saturation. Then the second oxygen form in which oxygen exists in the blood is what is the free form, the form that is not bound to hemoglobin, the dissolved form, the one that generates what the partial pressure, right, of oxygen. So that's the PaO2. So this is like the dissolved oxygen, and then we have what we have this, the bound oxygen, yeah, bound to hemoglobin. So these are the two things or the two major forms, right, in which oxygen exists in the blood. That determines the oxygen content, right, in arterial blood, right? So far so good. Everyone following me up to this point. Everyone got this up to this point. Okay, Victoria. So far so good. So in this case, the next thing I want us to explore is what will determine this dissolved oxygen. So what determines this guy? And then work our way right backwards. So what determines PaO2? So PaO2 depends on what? It's this dissolved oxygen, this oxygen in the gaseous form in the blood. Most of the how do we get oxygen to the blood? That's the question. In the dissolved form, right? Is what is the lung. So that's the major function of the lung. The major function of the lung, everything you do in the lung is to get oxygen, right, into the blood eventually. So let's say this is the major setup of the lung. This is the alveolus, right? We have the blood vessel supplying that alveolus. Yeah, and this represents maybe the airways. Yeah, the neck of the bottle, and then we have a bottle that looks like the alveolus, and then we have the blood vessels supplying the lung. How will I get oxygen into the blood? What is the first thing that must happen? What does the lung do first? Get air, right, in first. So we need to get oxygen first into the alveolar space, to the alveolus. So where is the oxygen coming from? It's coming from what? Atmosphere, right? So we're getting what? Atmospheric oxygen into the lung. So this is the concept of what? Lung ventilation. Get air into the alveolus, and that will create what? Pressure? Alveolar partial pressure, right, of oxygen. Whenever you have gaseous molecules accumulating, they create what? Pressure, partial pressure. And this partial pressure is like the driving force, right? It's the driving force in the presence of this PaO2 and an intact diffusion barrier. Oxygen can move from the alveolus into the what? Into the blood, and that will create what? PaO2, the small a O2. dissolved oxygen in blood, or gaseous oxygen. So oxygen is in the air, gaseous form, gets it into the lung. This is the whole concept of taking breath in or inspiration, getting air or oxygen from the atmosphere into the lung. Then that the pressure generated by the oxygen in the lung will push oxygen across the diffusion barrier, right, into the blood and create what the PaO2, the small aO2, right? So based on this mechanism, if I ask you what are the things that will decrease, that will affect small aO2, what are the factors or things that may decrease small aO2? And whenever a patient has, right, low small aO2, that's what we call hypoxemia. So hypoxemia is low small aO2. The small a, arterial oxygen, is low, dissolved oxygen. So based on this mechanism, what are the mechanisms, what are the things that can decrease this? First, a patient might be breathing in what? Oxygen poor air, starting from the atmosphere itself. They're breathing in oxygen poor air, so decrease FiO2, decrease oxygen in the atmosphere. That would be the one mechanism. If I'm breathing in oxygen poor air, there'll be less oxygen in the alveolus, there'll be less oxygen in the blood subsequently. That's one mechanism. Second mechanism of hypoxemia, why will small aO2 be low, is if a patient gets oxygen in, the air rather is oxygen rich. The air is fine, oxygen rich, but the problem is that what the patient there's something wrong with the barrier. So there's a block here at this point, even before right here. So there's no movement of oxygen from the alveolus into the blood. Something is wrong with the diffusion barrier, right? So we're looking at what diffusion impairment, right? Diffusion impairment. Patient has pulmonary fibrosis. There's fibrous tissue here, right? Patient has emphysema. There's destruction of the alveolus, the type 1 pneumocytes. So all these things can cause like diffusion impairment. So oxygen can move from the alveolus into the blood through the barrier properly. That's one mechanism. Another mechanism could be that I can't even there's an obstruction, right? Either there's an obstruction here preventing proper air from entering, there's an obstruction in the airways preventing oxygen from moving in, or there's a block in the vessel preventing blood, right, from perfusing ventilated alveolus. So this is what we call VQ mismatch, like pulmonary embolism, airway obstruction, right? So patient vessels, alveolar spaces are perfused, but there's a block in their airway. Oxygen can't enter. They are not ventilated. Or there's ventilation. I'm getting oxygen in, but there's block in the blood vessels. There's decreased perfusion, like in pulmonary embolism. That's VQ, right? Mismatch. That's another mechanism. Another mechanism will be, what if I divert blood completely away from the lung? There's no blood flow to the lung at all. That's what we call shunt. Yeah. So blood is going directly from the right heart to the left heart. Like if a patient with tetralogy of Fallot, right, or some cyanotic heart disease, so there's no blood going to the lung at all. Or patient has some sort of arteriovenous malformation in the lung, blood is bypassing the alveolus completely. It's being shunted from one vessel to the other, or from the right circulation to the left circulation without going through the lung. That'll be shunt. Yeah. Another mechanism you might also think of would be what if something is filling the alveolar space. So imagine there is like pulmonary edema or pneumonia, where the alveolar spaces are completely filled up with fluid. Also, there's no way oxygen can make it in, right? Yeah. So you're looking at what alveolar filling defect. The alveolar spaces are filled up with fluid, exudate. like pneumonia, pulmonary embolism. Yeah, there's no way oxygen can make it into the alveolar spaces. This will also will prevent oxygen from getting to the blood, right? So many, right, mechanisms here, but these are the five major ones, and they make sense. Something can deduce, right, from just this process. Any question on this so far? All right. What is V? Ventilation. Q is what? Perfusion. So air is not getting in, or there's no blood flow. Or so I'm getting air in into the alveolar spaces, but there's no blood flow, no perfusion. That's a VQ mismatch. Or there's perfusion, there's blood flow, but there's no ventilation. There's no air getting to the lung. That's also a VQ mismatch. Normally, both should be normal. The air coming to the lung should match the blood flow to the lung so that I can have adequate oxygenation. So anything that affects one more than the other, lowers one more than the other, right, will cause a mismatch and poor oxygenation of blood. PE is what? What does PE do? Pulmonary embolism. What does it do? Does it affect ventilation or perfusion? Right, it lowers perfusion. So ventilation is still normal. Exactly. So asthma will obstruct the airways, bronchiectasis, foreign body aspiration, they obstruct the airways, so they decrease ventilation, but there's still perfusion, right? So that will also be a VQ mismatch. Yeah, good. Okay, all right. Okay, good. Have you guys heard of AA gradients? AA gradient. This one, capital A minus small a gradient. And how do you use this? So basically, if you look at the formula we have here, let me clean this up. Sorry, this illustration we have here. Let me clean this up a little bit. So the capital A in the A gradient is what? Alveolar partial pressure of oxygen. That's what the capital A stands for. The alveolar partial pressure of oxygen. And the small a is the arterial partial pressure of oxygen, right? Like we have here in this diagram. So let me clean this up a little bit to tell you how you can use that gradient. Okay, so capital A. So we know, right? So bringing oxygen in from the atmosphere comes in capital AO2. We get this diffusion, right, into the blood, small AO2. So A gradient is the difference between what? Alveolar partial pressure of oxygen and arterial partial pressure of oxygen. Normally, this should be less than, in most cases, less than 15, although it normally increases, right, with age, normally, but ideally, most cases should be less than 15 to 20. This difference, the difference between them. But how can I use this if I'm doing hypoxia? I can use these gradients to kind of categorize, right, or determine the mechanism of hypoxia. Oh, there's one mechanism I didn't add here. Also, don't forget hypoventilation, right? Hypoventilation. So sometimes there's air. Patient has normal atmospheric air, but the patient cannot bring air in because of shallow breathing or low respiratory rate, right? Or low tidal volume, right? Like a patient with respiratory muscle paralysis, like myasthenia gravis, right? Diaphragmatic paralysis, patients that is suffering from opioid overdose, causing CNS depression, right? Or respiratory depression. So those will be hypoventilating. The air is rich in oxygen, but they can't breathe it, they can't bring it into the lung, right? Hypoventilation too can cause hypoxemia. Okay. So going back to the air gradient, if so, look at the first three mechanisms. This one. In these cases, in if the cause of hypoxemia is either low FiO2, like high altitude, right? Breathing in air at high altitude is low in oxygen, or hypoventilation, diffusion impairment, or VQ mismatch. The AA gradient is usually what? Is usually wide in those cases. Sorry, usually normal, forgive me. Normal rather. Normal, not wide, normal. Because if you notice in hypoventilation, FiO2 issue, no. In these two rather, in FiO2 issue or hypoventilation, the first two, if the mechanism of hypoxemia is low, breathing in low oxygen air, oxygen that is low in air that is low in oxygen, like high altitude, or hypoventilation, patient is hypoventilating, what will happen is that what the PaO food, capital O2 will be low, right? Because the air I'm breathing in is low, or the air I'm breathing in is normal in oxygen, but the patient cannot bring it in to the lung. Either way, capital AO2 is low. Capital AO2 is low, then small AO2 will be low too. Since they are both low, the gradient will be normal. The difference between them will remain what? The same. It will still be normal. So if you see hypoxemia, you subtract capital A from small a, is still within like 15, between 15 to 20 or below. That's normal A gradient. The mechanism is either what? Low FiO2 or hypoventilation. The patient is either breathing in a low oxygen air or they are not bringing air into the lung at all. That will explain why the alveolar oxygen 2 is what is low. And then the arterial 2 will be low, right? Yeah. And the A gradient will be normal because they are both low. But if the mechanism of hypoxemia is from 3 to 6, diffusion impairment, because if you notice now, if the problem is here, if a patient has diffusion impairment here, can they bring oxygen into the lung? Yes, they can. So capital A is normal. But there's a diffusion impairment here, right? So small a will be low for sure. But they can bring oxygen into the lung, but the oxygen cannot diffuse into the blood. So the A gradient will be wide. Capital A is normal, small a is small, the difference will be wider. If it's a VQ mismatch, especially if it's due to low perfusion, patient can still get oxygen into the lung. If it's like a perfusion issue primarily, but they cannot, right? They can get oxygen into the lung, but there's no blood flow to pick up the oxygen. So small a will still be low, capital A will still be normal. Even in case of obstruction, V can be a little bit low in that case because of airway obstruction. However, it may not cause it may not significantly, right, decrease capital A, especially if it's like one lung or something like that, right? So generally the consensus is most VQ mismatches will still have normal, they might still have slightly low or normal capital A, but they're going to definitely have low A, right? So the difference will be increased because small a will be small, it's going to be lower, right, than the capital A. Yeah, so that will also look like diffusion impairment. There will be wide A gradient. Shunt, still same thing. You get blood away from the lung. I'm getting oxygen into the lung, so capital A is normal, but there's small a will be low. Alveolar filling defect, yeah, it's also going to have wide, right, A gradient. So 3 to 6 will be wide or increased A gradient. Mechanism 1 and 2 will be normal A gradient, but the other 4 wide A gradient. So this is what you use A gradient to do in hypoxemia. You want to determine the mechanism of the hypoxemia. So if it's normal A gradient, think of either high altitude, low FiO2, or patient has hypoventilation. If it's wide A gradient, then think of the other mechanisms except those two. How can you separate FiO2 from hypoventilation? You can now check what? You can check CO2 levels. If a patient is breathing in a low oxygen air, for instance at high altitude, they are going to compensate by what? Hyperventilating. So PaO2 is usually what? Is usually PaCO2 rather, CO2 is usually low. Patient will be hyperventilating to compensate for the low oxygen they are breathing in. Yeah, so they're going to be blowing off more CO2. So PaCO2 will be low. They're going to develop respiratory alkalosis. While if it's hypoventilation, they're not bringing enough air in, neither is the patient breathing enough air out, which means CO2 will accumulate in the blood, and they usually call hypercapnia. PaCO2 will be increased if it's hypoventilation. So patient has hypoxemia, low small AO2. You check the A gradient, it's normal. You're thinking low FiO2 or hypoventilation. Check the CO2 levels. CO2 is low, low FiO2, patient hyperventilating. CO2 is high, CO2 accumulates, is definitely hypoventilation. For the ones with wide A gradient, you can further separate them by looking at what? By looking at response to oxygen supplementation. If I'm shunting blood away from the lung, or the alveolar spaces are completely filled with fluid, which means oxygen can't even get in at all, or I'm taking blood away, blood is taken away from the lung, blood is not going through the lung at all, completely not going through the lung, like a right to left shunt in somebody with cyanotic heart disease, then even if you give them oxygen supplementation, right, they are never going to improve because oxygen can't make it to the alveolar, or it cannot, or there's no blood flow at all to pick it up. So shunt and alveolar filling defect will have what? They're going to have no response to oxygen supplementation. Why, if it's diffusion impairment or VQ mismatch, there's a response to oxygen supplementation. So oxygen levels will rise, PO2 will rise if you give them oxygen. So you can separate those four from each other, right, using that. But this basic physiology, right, I definitely want you guys to keep in mind and know how, right, to think about this. First, what is hypoxemia? Low small AO2 in the blood. The dissolved oxygen is low. The major player that determines small AO2 is the lung, right? Not everything happens at level of the lung. For most of them happen at level of the lung for small AO2 dissolved oxygen, which makes sense. It's the gaseous oxygen. So either we need, right? So major mechanisms: oxygen poor air, low FiO2, high altitude would be example. Hypoventilating, muscle paralysis, neuromuscular junction disorders, opioid toxicity, alcohol intoxication, benzene intoxication, like CNS suppression, again called hypoventilation, diaphragmatic paralysis, etc. Right, phrenic nerve injury, cannot fall under that category. Diffusion impairment, pulmonary fibrosis, emphysema, right? And yeah, anything that affects diffusion, all right, we'll be on that side. VQ mismatch, typically pulmonary embolism or things that cause airway obstruction. Shunt, the complete diversion of blood away from the lung. So looking at a right to left shunt or AV malformations or fistulas. Alveolar filling defects, fluid accumulating in the alveolar spaces, pulmonary embolism, pulmonary edema, pneumonia, ARDS, right? Yeah. So what role does A gradients play here? A gradients can help me differentiate, right, between the mechanisms. If the A gradient is normal, then I'm dealing with either low FiO2 or hypoventilation as the mechanism of what? Hypoxemia. And if the A gradient is wide, then I'm dealing with the other four: diffusion impairment, VQ mismatch, shunt, or filling defect. How will I separate between those with normal A gradient? Check CO2 levels. Patients with low breathing in oxygen poor air will be hyperventilating to compensate. So they are blowing off CO2. So CO2 will be low. Patients that are hypoventilating will be retaining CO2. So CO2 will be high. I can separate diffusion impairment and VQ mismatch from shunt and alveolar filling defect by looking at response to oxygen supplementation. Diffusion impairment and VQ mismatch will respond to oxygen supplementation, but shunt and alveolar defect will not respond. Or PaO2 will still be low even if you give them oxygen. Yeah. So these are the mechanisms of what hypoxemia. Guys, you get this? Stay with me. Okay. Any questions on this before we move on? Which last part? Which last part? Can you pinpoint it?